Good afternoon and nice to meet you. I'm Dr. Lee from Seoul National University Hospital, Seoul, Korea. So you may know or may not know some medical situation in Korea is now really bad. Since 1 month ago, some crazy Korean president declared something suddenly. So we are now very in trouble. But hopefully very soon we will solve this problem. So anyway, I really appreciate some organizing committee for the invitation. This is my talk today. And among various treatment modalities, surgical section shows mostly better than any other non-surgical treatment. However, even after curative resection, frequent de novo recurrence can be developed from the carcinogenic background liver. Therefore, liver transplantation is superior to resection if it is non-advanced stage. So I would like to talk more about the recent update in these two surgical modalities. So I would like to introduce minimal invasive surgery, MIS, and ICG application in surgical management for the HCC. As you can see, you know, minimal invasive surgery, MIS, gains growing popularity nowadays. Since 2015, laparoscopic apoplectomy has been popularized suddenly in our center. The proportion of laparoscopic apoplectomy for malignant tumor, red line, is currently 70 to 80% in our center. One survey proved that more than 60% of Korean centers perform liver resection for HCC by minimal invasive approach in more than half of the cases. This recent popularity is due to improvement of instruments such as 3D flexible scope, UHD screen, ICG fluorescence camera, and so on. Personally, the 3D flexible camera was the key factor to enable to minimal invasive approach for me. As MIS is gaining popularity, the guidelines are evolving and many studies dealing oncological issues are published. The previous guidelines suggested selective application of MIS in liver surgery. For example, posterior superior segment were considered as an unfavorable location. However, it became old recommendation nowadays as advancement of MIS technology. Interestingly, anatomical resection of segment 7 is also difficult in open surgery. Furthermore, rather than segmentectomy, easier alternatives such as right posterior sectionectomy or right hemianthectomy can be done without any difficulties under the laparoscopic approach in real practice. Oncologically, as well, laparoscopic approach for the posterior superior segment showed the comparable outcome with open surgery. And MIS gains growing popularity in the living donor area. Among various incisions, laparoscopic donor hepatectomy using fundus incision for graft extraction became popular. So our center started the pure laparoscopic donor hepatectomy in November 2015, and recently about 85 to 90% of donor hepatectomies, mainly right hemianthectomies, are performed under the pure laparoscopic technique without any selection criteria. Personally, during 8 years since January 2016, I have performed all cases 100% on the pure laparoscopic approach without any exclusion and no open conversion cases. As you can see in this graph from multi-center study in Korea, including my center, the proportion of laparoscopic donor hepatectomy accounted for more than 80% in 4 centers. It's an old one in 2018. As we already expected, the laparoscopic fundus incision showed The best wound satisfaction among various types of incisions in my previous questionnaire studies. Compared to the inverted L, upper midline incision was better, but the best was a fundus steel incision. Furthermore, as you can see in this propensity matching analysis study from our center, laparoscopic donor hepatectomy showed comparable outcome with open donor hepatectomy. Furthermore, intraoperative bleeding and hospital stay is significantly less in lap group. However, operation time is longer in the laparoscopic group, similar with other reports. After overcome the learning curve at 43 cases, the lap surgery can be similar or better surgical outcomes than open. In my personal series, the mean operation time after learning curve was 3 hours, 180 minutes, significantly less than my open upper midline group, as well as the initial group. The time to removal of graft was similar between upper midline and the recent lap group, 2 hours. And the blood loss is less in lap group. Hospital stay is also significantly less in recent group. Also, recent group showed acceptable rate of major complications. There was fewer grade 1 complication in lab group and no differences in more than grade 2 complications. There was no significant difference in recipient overall survival and graft survival between the two groups. However, there is a higher biliary complications in recipient from lap donor grafts. It might be related with relatively longer roaming stream time or bile duct division method. However, as accumulation of experience, my surgical techniques is evolving to reduce the risk of complication in both donor and the recipient. So as accumulation of MIS in donor surgery, it starts to apply in recipient surgery. In recipient surgery, there are concern of massive bleeding due to coagulopathy and highly difficult surgery. However, MIS is already started to apply in recipient surgery. MIRS can be classified into 3 different types: small incisional surgery, lab-assisted, and totally lab or robot surgery. Let me start with the small incisional recipient surgery. During 10 years before starting lap donor hepatectomy, I preferentially used upper midline incision. When you look at the video, there are 6 tips to overcome the limitation associated with a small incision, especially how to do right liver mobilization safely is important tip. I recommend use a malleable instead of a hand to do a right liver mobilization. Based on this experience in donor, the full recipient procedure can be done under upper midline incision without a laparoscopic assistance. Under the 16 centimeter incision, all procedures can be done safely in this case. The liver is almost out, and then graft is inserted. I prefer the total IVC grafting in recipient surgery, so exactly the same technique will apply even small upper midline incision. Now I would like to introduce the next step, the laparoscopic assisted recipient surgery. Right liver mobilization is somewhat difficult and risky under the upper midline incision. Therefore, right liver mobilization can be done more safely by laparoscopic approach. The French group reported their first case of laparoscopic assisted explant hepatectomy, then following graft implantation under the upper midline incision in DDLT setting in 2020 and the initial series of 6 cases in 2022. When you look at the title, Dream or Reality by Thomas Paper. In LDLT setting, our team reported the first series of lab-assisted recipient surgery. Professor Saw, my senior professor's 5 cases, and my 10 cases were reported. I started minimal invasive recipient surgery in June 2020 with 6 cases of laparoscopic mobilization, and then following surgery on the upper midline incision. Then the timing of making upper midline incision has been delayed step by step up to full separate dissection of each hilar structures for the anastomosis. And the first robotic graft implantation was tried in May 2021, but needed open conversion due to bleeding and arrhythmia during portal vein anastomosis. Fortunately, all 10 initial case series, including robot trial case, showed a favorable outcome. After experience of recipient surgery on the upper midline incision, we moved to the next level, totally lab or robot assisted recipient surgery. Our team, Professor Saw succeeded full lab LDLT. When you look at the title of this report, Dream Come True is the answer for the title of Professor Dongmak's French team's paper, Dream or Reality, is reality. Around that time, our team also succeeded lab explant and hybrid lab robot graft implantation, which means until the whole vein anastomosis until perfusion, laparoscopically done, and then hepatic artery and bile duct anastomosis were done by robot assisted. Immediately after this, our team also succeeded the lab recipient hepatectomy, followed by robot assisted graft implantation. After explant hepatectomy by laparoscopically, from hepatic vein anastomosis, robot assisted system was used. This is a video of laparoscopic recipient hepatectomy, followed by robot assisted legal graft implantation. Same technique I used in open surgery, so-called high hilar dissection was used. So just the portal vein is dissected, and in this case, hepatic artery, the proximal part is dissected and clamped, and then just cut the whole structures before the mobilization first, and then cut the whole structures as an envelope. And we don't need to close the graft side, recipient side opening, because due to abdominal pressure, there's no bleeding, and the vitreohepatic IVC is also easily dissect because of some holder to separate view of laparoscopic camera. Usually I prefer the left to right side dissection, and then breathing control, and then hilar dissection. The bile duct is prepared. And the graft is removed from the fundus incision, and the graft is inserted through the fundus incision again. Before that, externally, cheek wood clamp is applied for the IVC clamping, and the rubber is docking, and the graft is wrapped by a vinyl bag, and insert and remove the right hepatic vein and anastomosis. Our skip details. And finally, our team reached total robot-assisted recipient surgery. And this slide summarizes the changes of wounds and the tropocyte by different minimal invasive recipient surgery in our team. And after accumulation of experience, the anastomosis time is now much shortened. In this case, hepatic vein anastomosis takes 25 minutes, and the portal vein anastomosis takes 17 minutes. Also, some coordination with donor surgery was improved. Therefore, the cold ischemic time, which was quite long in previous case, but it was also shortened to the 1 hour, 2 hours, 120 minutes. So now I would like to introduce the ICG application. ICG has a similar uptake and excretion mechanism with two pre-Morpheus contrast media in MRI. So nowadays ICG applied in various fields: liver mapping, intraoperative cholangiography, tumor visualization, and liver transplantation. The most frequently used of ICG is liver mapping. Resected area or remnant area was stained with ICG. The demarcation line facilitates anatomical resection. Positive staining or negative staining are used accordingly. So anatomical liver resection is traditionally done according to the superficial marking generated either by dye staining of the pore branch or by temporary clamping of the blood supply. Compared to the Indo-Carmine dye method, ICG showed better performance. For positive staining, ICG can be injected directly via pore vein or via IV after clamping of pedicle supplying the remaining segments. This video is sustaining positive staining of right anterior section. ICG is useful to localize the tumor, especially a small tumor near the surface. These are the examples of fluorescence pattern of HCC. Left shows the well-differentiated HCC with total fluorescence. Right side shows partial fluorescence pattern of poorly differentiated HCC. This figure tables shows the different pattern of fluorescence images of ICG in hepatocellular carcinoma and liver metastasis. While differentiated or moderately differentiated HCC shows the homogeneous or partial fluorescence pattern. However, poorly differentiated HCC or liver metastasis shows the green fluorescence type. So metastatic lesion of HCC was not easily found. However, using ICG technique, HCC peritoneal seeding, retroperitoneal metastasis can be detected easily. In living donor hepatectomy, ICG cholangiogram is routinely used to identify the division point. After resection or bioduct anastomosis in LDLT, the leakage can be detected by ICG technique. So MIS continues to gain popularity in hepatic resection and expanding to LDLT procedure. ICG widens its application. So Korean Liver Transplant Society is now organizing the international conference LT Update 2024. As the president of KLTS, I would like to meet you again in this meeting in Seoul. Please mark August 29 and 30 in your calendar.